Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
My name is Smita Patel. I'm a cardiothoracic radiologist, and I'm going to be talking on acute intramural hematoma, which is a well-recognized cause of acute aortic syndrome that is important to accurately diagnose, as this helps guide prompt management of this life-threatening emergency. I have no disclosures. In this video, we're going to learn how to identify acute intramural hematoma on CT, to identify its high-risk features, and to review potential complications. Acute aortic syndromes include acute aortic dissection, acute intramural hematoma, and penetrating atherosclerotic ulcers. All these entities share similar pathogenesis, clinical presentation, and imaging protocols. And they can lead to life-threatening complications such as aortic rupture, acute aortic regurgitation, cardiac tamponade, myocardial ischemia, malperfusion, and acute stroke. For the purposes of this video, I'm going to focus on acute intramural hematoma, which accounts for 5 to 25% of all acute aortic syndromes in the Western world, but the prevalence is significantly higher in the Asian literature for about 30 to 40%. An acute intramural hematoma is a distinct pathologic entity which is characterized by hemorrhage in the medial layer of the aortic wall. It is clearly identified on a non-contrast CT as a crescent of high attenuation, which can be easily masked on contrast-enhanced imaging, and it's therefore important to obtain a non-contrast CT in all cases of suspected acute aortic syndromes. There is no flow that is seen within the false lumen with acute intramural hematoma, in contrast to typical aortic dissection where we have flow in the true and false lumen. An acute intramural hematoma is thought to occur from rupture of the vasa vasorum, but recent theories suggest that there might be micro tears in the intima that lead to the formation of intramural hematoma. When we look at the location, this occurs most commonly in the descending thoracic aorta in 60%, followed by the ascending thoracic aorta in 30%, and the arch in 10%. Classification is similar to typical aortic dissection, where it's type A if the intramural hematoma involves the ascending thoracic aorta, and type B if it does not involve the ascending thoracic aorta. Like typical aortic dissection, the majority of the acute intramural hematomas that are type A are treated surgically, and those that are type B are treated medically or may need endovascular treatment or surgery. This is a case of an acute intramural hematoma type A, which involves the ascending thoracic aorta, and you can see that this could possibly be missed on the contrast-enhanced CT. We also see low attenuation along the pulmonary artery, which on the non-contrast CT is higher in attenuation, and this is a shared sheath hematoma. The ascending thoracic aorta and the pulmonary artery share a common adventitial sheath, and when there is a subadventitial rupture of the ascending thoracic aorta, blood can seep into this common sheath, and it can be of varying amount and can even compress the pulmonary artery. This is a case where we have an acute intramural hematoma in the distal arch and descending thoracic aorta, a type B acute intramural hematoma, and a large number of these patients can be managed medically. However, acute intramural hematomas can progress in about 40% of patients requiring intervention. They can basically extend more proximally or distally, or they can lead to complications, and hence long-term follow-up is required with a possible need for late intervention. What about the CTA report? What's important for us to note is What is the total extent of the acute intramural hematoma? What is its proximal extent? What is the distal extent? Does it involve any of the branch vessels? What is the thickness of the intramural hematoma? What's the maximum diameter of the aorta at the site of the intramural hematoma? And whether there is the presence of a penetrating atherosclerotic ulcer, oftentimes associated with a limited acute intramural hematoma. Features of complicated intramural hematoma include malperfusion, periaortic hematoma, pericardial effusion with cardiac tamponade, and rupture. And clinically, they may be persistent, refractory, or recurrent pain. When we look for high-risk imaging features with type A acute intramural hematoma, these include a hematoma thickness of 10 millimeters or more, a maximum ascending aortic diameter of greater than 45 millimeters, a focal intimal disruption with an ulcer-like projection in the ascending aorta or arch, and the presence of a pericardial effusion on admission. High-risk features with type B include a hematoma thickness of 13 millimeters or more, a maximum aortic diameter of more than 47 millimeters, a focal intimal disruption also like projection in the descending thoracic aorta if it develops in the acute phase, and an increasing or recurrent pleural effusion. Other high-risk features that occur in both type A and type B include progression of aortic dissection, increasing aortic diameter, and increasing hematoma thickness. In this patient, on presentation with an acute intramural hematoma, we have a small focal outpouching, which is an ulcer-like projection, which has a communicating orifice of greater than 3 millimeters. And this is a high-risk feature. These focal intimal disruptions occur in about 32% of type B intramural hematomas, and they significantly predict cardiovascular or aorta-related death. 3 months later, on a follow-up CT in this patient, we see a large ulcer-like projection at about 5 to 6 o'clock position at the same level as the left atrium, as we see on this initial image, and another large ulcer-like projection at the level of the diaphragm that wasn't present before. And this patient underwent endovascular repair. This should be distinguished from this entity where we see isolated pockets of contrast within the false lumen, but in this case, what we see is that a vessel is leading to this contrast pool, and you see also a small thin connection between the true lumen and this contrast pocket. This connection may be absent in several cases, and this usually occurs due to shearing off of the intercostal arteries at their origins at the time of aortic dissection. This is not considered high risk. In this patient with an acute intramural hematoma at presentation, this was the case that I showed you earlier, they did not undergo surgery because the patient was at very high risk for surgery, so they were followed closely. And at 8 months on the follow-up CT, this patient developed a complex aortic dissection with aneurysmal degeneration of the ascending thoracic aorta, and they did have to go surgery at that stage. This is a case where you have a type B acute intramural hematoma that ruptured and led to a hemothorax, a mediastinal hematoma, as well as a hemopericardium. And this patient basically had the rupture at the level of the distal arch and descending thoracic aorta. You can see this focal outpouching both on the axial view as well as the volume rendered image. This patient underwent endovascular treatment, endovascular repair with excellent results at 7 months with complete resolution of the intramural hematoma and also the hemothorax and pericardial effusion. So in conclusion, non-contrast CT is very important to obtain in patients with suspected acute aortic syndromes, as it really helps to accurately identify this high attenuation crescent, which is diagnostic of an acute intramural hematoma in a patient presenting with chest pain. It's important to measure the thickness of the intramural hematoma and to look for ulcer-like projections, and as well as those other things we had mentioned as high-risk features. Recognize complications such as aortic dissection, aneurysmal degeneration, as well as rupture. These are the references, and I thank you very much for your attention.